information. So we have to make sure you have that. We have to make sure that you know how to be safe in the clinical setting and that you start to build your clinical thought process, that critical thinking becomes easier and easier. Today it may be harder than it will be your 4th semester, okay? So we've just got to keep adding to your skill set. So today when we talk about IV medication, especially IV fluids, you know, when you go into the hospital, you see a lot of people on fluids, right? They're being rehydrated in some way. We need to make sure as nurses that we know what those fluids are doing to the body, because we're the last line of defense before a medication is given, right? In theory, the doctor knows what he or she is doing and they're prescribing the exact thing that the patient needs. The pharmacy is going to check it and you're going to check it, right? But ultimately, we're that last line of defense, so we've got to be able to think critically about how that medicine affects the body so that we can catch, okay, well, this patient is fluid overloaded and you want me to give them normal saline at 150 an hour. Yesterday, Mrs. Hendricks was talking about our lungs as buckets, right? Buckets of air or buckets of fluid. If they're fluid overloaded, fluid loves to collect in those lungs, and then there's not room for the air because air and water don't mix too well, okay? So we have to be able to think critically. If that was the case, I would call my doctor and say, hey, I held this because that's nursing discretion, but you still have to call the doctor because that's out of your scope of practice, right? You can't make an order. You have to call them and say, I didn't give this at this time because I wanted to check with you about this. This is the current assessment of the patient. And the doctor may say, yeah, I'm going to hold that for now, or, well, their kidneys are such that we're going to need to do something, so, etc. Okay? But the doctor makes the order about the administration. But you as a nurse are on safety patrol at all times. And so you can say, hey, it doesn't seem safe to give this at this time. Here's what I see with my assessment. Here's what I hear with my assessment or the labs, okay? So we've been talking a little bit about hypotonic, isotonic, and hypertonic, right? We know that we came up with some different ways to remember hypo cells. Hypotonic cells are like hippo cells. What does that mean? They swell, they bring that fluid in, right? And then hypertonic cells, they're so hyper that they're skinny. And then isotonic, we think iso, okay, everything's balanced, right? We're having the same amount coming in as we're having go out. I like YouTube. I'm a visual learner, so when I was in nursing school, charts helped me, pictures helped me, and so did some videos. I couldn't just do videos, that wasn't enough, but it would help sometimes to clarify. This feller here, I'm sure he likes being called a feller. This nurse here on Simply Nursing is really wonderful about breaking things down, and he's not boring to listen to. Sometimes their voices are monotone or they stumble all the time and you just check out. He's pretty entertaining, and if I'm 100% honest, he's not hard to look at. So I know this video is a little bit of time, but it gets a lot of the concepts in there. I want you to try to pay attention. I know somebody puts on a video, where's your mind? I've got to make this for dinner. I got to pick up my kid. I'm going to have to scrape my car. I know, but try to dig in and focus on our time, because that'll be less studying time you have to do in the future, okay? I'm trying to do very practical things in class that make the most of what you need to know. We're ready.
Artist here, and welcome to SimpleNursing.com. Today we're talking about isotonic, hypotonic, and hypertonic solutions. So kind of like the three little bears, or the three little hippos. One is too much, one is too little, and one is just right. All right, guys, first we have hypotonic fluids, which we call hippotonic fluid, because fluid goes into the cell, making the cell swell, making it big and puffed up and swollen, just like a big hippo. So what are hypotonic fluids? Well, they're just solutions containing a lower concentration of salt or solute than ICF, or basically fluid inside the cell. They're basically diluted fluids having less salt and more water than your body fluids. So the simplest way to remember this is hippos love water, and hippotonic fluids are filled with water. Hypotonic fluids have a lower osmolality, basically a less concentration than body fluids. because all of that water dilutes their concentration. Now, hippos are massive and they eat a lot because they're very hungry hippos. And this is simple to remember hypotonic solutions in a way that they're usually half, 1/3, or even 1/4 of normal saline. So guys, write this down. This is a list of hypotonic fluids. Half NS or 45% NaCl, sodium chloride. 1/4 NS or 20% sodium chloride. 1/3 NS or basically 0.33% of sodium chloride. And 2.5% dextrose in water, as well as D5W. So caution, let's slow this down real quick because D5W is a very unique solution and may be both isotonic as well as hypotonic, but never hypertonic. So please stop what you're doing and listen up real quick. Now, D5W is isotonic in the bag and hypotonic in the body. Now, before you go like OMG, just understand that sugar is the big culprit. Inside the bag, the sugar is thick and floating around in there. But once inside the body, the sugar is eaten up by all the cells in your body. And all that's left is our good old-fashioned hypotonic fluids. Now let's write down these very important nursing considerations with hypotonic fluids. So first things first, never use hypotonics with ICP patients. It will increase their intracranial pressure and cause brain swelling. Also, any solution with dextrose, which is just fancy words for sugar, is never used for diabetic patients with hyperglycemia problems, basically high blood sugar problems. Once again, dextrose is sugar and will make more sugar in the body. Okay, so what is the function of hypotonic solutions and why do we use them in people? Well, the function is used mainly to replace fluid inside the cell, the ICF, intracellular fluid, and used for conditions that cause cellular dehydration. So guys, please slow it down and write that down. Cellular dehydration is when your cells are thirsty. So for example, cellular dehydration happens with hypernatremia, basically too much salty sodium in the body. All that salt in the blood adds up and piles up in the bloodstream and sucks out all that fluid inside the cell to outside the cell, causing those skinny cells to shrink even more, known as cellular dehydration. Now, condition number 2, HHNS, which is hyperosmolar hyperglycemic non-ketonic state. What's your language? Oh, sorry. Also called HHS for short, which is basically a type 2 diabetic disorder with uncontrolled high blood sugar. All that super thick blood sugar concentration makes the cells dehydrated by drawing fluid out of the cell. Now, caution, again, do not use D5W. The D is dextrose, and dextrose is sugar. Now, condition number 3, DKA, diabetic ketone acidosis. Very similar to HHS, but this time it happens to type 1 diabetics. It involves burning ketones, or protein molecules, instead of glucose sugar as a primary source of energy. But essentially the same thing happens here. Super thick, syrupy, sugary blood, and this makes cells dehydrated by drawing fluid outside the cells and making cells thirsty. But again, caution, don't use solutions with dextrose and sugar, guys. That's alpha, busted. Okay, guys, that's enough with the thirsty jokes, okay? All right, so let's talk about some key nursing interventions to keep in mind when using hypotonic solutions. So guys, please write this down. These are priority nursing considerations for hypotonic. They're never given for ICP patients. We don't infuse too rapidly. You want to infuse slowly. And we also watch out for hypovolemia signs and symptoms. Since hypotonic solutions draw more fluid into the cells from its surroundings, we never give hypotonic solutions to patients with ICP, intracranial pressure. Because just basically think about this. It's going to increase the intracranial pressure, or fancy words for it, increase the brain swelling, leading to brain damage. So all hypotonic solutions should be administered slowly to prevent this cellular edema, which is a key word for that class. Now, the last nursing consideration is excessive infusions of hypotonic solutions can lead to fluid depletion inside the blood vessels, leading to a condition called hypovolemia, basically low fluid in the body. Here are some signs and symptoms for low volemia, low volume of fluid. Tachycardia is usually one of the first signs we see, but also decreased blood pressure, cellular edema, as well as cell damage. So also be cautious with diagnoses like liver disease and trauma and burns. And once again, to wrap it up, no hypotonics for ICP patients. We infuse very slowly, and we watch out for signs and symptoms of hypovolemia, low volume of fluid. Next is our hypertonic fluid. The simplest way to remember this is to think of a hyper person. Now we all know that one person in our life that's super high energy, super hyper, and always peppy, bouncing off the walls and super skinny, super enviously thin, right? Because you have all that fluid escaping from inside the cell to outside, making those cells skinny and black. Now, what is a hypertonic solution? It's a solution containing higher concentration of salt or solutes than our ICF, fluid inside the cell. They're basically very thick, concentrated fluids inside the IV bag, thick like mud. Now, hypertonics have more salt and less water. So the more thick solutions having a higher osmolality, or basically higher concentration. This means hypertonic solutions will have higher osmotic pressure. Basically meaning they're pulling fluids toward themselves, kind of like a magnet, pulling that fluid out of the cell and making them very skinny. Or in fancy terms, pulling fluid out from inside the cell, the ICF, to outside the cell, the ECF, causing the cells to shrink by osmosis. Because where there is high salt, water gets pulled there to equalize the osmolarity and keep it just right for homeostasis. So here's a little memory trick to help you remember hypertonic solutions. These solutions have numbers like 3, 5, and 10. So it's easy to remember those three numbers. The 3, the 5, and the 10. Hypertonic fluid examples are 3% normal saline, 5% normal saline, D10W, D5W half NS, D5LR, lactated rigors, and D50W. So what is the function of these solutions? And why do we use them in our patients? Well, the main function is to draw fluids out of the cell into the vascular space, basically inside the bloodstream. We use them for hypovolemic patients with low fluid, heat-related disorders like heat exhaustion, and even peritonitis, an inflammation of the peritoneal cavity of the abdomen bracket. So let's talk about some key nursing interventions to keep in mind when using hypertonic solutions. Now, guys, priority nursing considerations here, so write these down. Infuse slowly, not too rapidly like a big bolus. If administered rapidly or in large quantities, hypertonic solutions may cause a big massive fluid shift and overwhelm extracellular fluids. They'll basically have all this fluid outside the cells. Well, why is this a big problem? Well, this can domino into an effect like cellular dehydration and even a bigger problem like fluid volume overload. So here are some signs and symptoms for fluid volume overload to watch out for. Big bounding pulses, high blood pressure, JVD, basically jugular vein distension in the neck, crackles in the lungs, basically fluid in the lungs, and possible edema. So please be cautious when administering this fluid. Finally, let's talk about isotonic fluids. These are my favorite because it's iso perfect. Not too big, not too skinny, they're just so perfect, causing no fluid shifts. So fluid remains intravascularly, inside the blood vessel. And they don't cause any fluid shift because the osmotic pressure is the same, both inside and outside the cell, so it's iso perfect. It has a perfect balance. Now, as mentioned before, isotonic solutions have the same consistency as normal human blood cells, and thus very little osmosis, or basically the moving of fluids occurs. Since they're just like human cells, they have the same osmolality as body fluids. So here's a list of isotonic solutions you may run into, so write these down. So 0.9% normal saline or LR lactated rigors contain potassium. So guys, be cautious with your renally impaired patients. This could cause hypervolemia, basically too much potassium. Secondly, no liver impaired patients. The liver cannot metabolize lactate when it's impaired. So guys, don't administer to patients with cirrhosis or even hepatitis or any other liver condition. Now, as said before with our hypotonic fluids, D5W is isotonic in the bag and hypotonic in the body. Now, before you go like, OMG, just please understand that sugar is the culprit here. Inside the bag, sugar is thick and exploded in there. But inside the body, sugar is eaten up and metabolized by the cells isotonic in the bad and hypotonic in the good. So to wrap this up, what are the fun watching for our full video and new quiz bait? Click right up here to access your quiz.
I just like him. He's kind of a hoot and he breaks things down and I think makes it easier to understand. There's lots of resources online for reviewing some material that when you read in the book, your head starts to hurt because there's so many little pieces. And so sometimes that's helpful to just like summarize, kind of like my charts that I like, summarize the most significant data. That doesn't mean there's not more to the story, but you got to start somewhere, right? Signs, what is it? How does it work? Signs and symptoms. What do we watch for? What's the end result? Those are kind of the things we see over and over as nurses. So pulling out that important information. We're going to jump into your PowerPoints. If you have those with you, pull them on up. It's going to be the concepts of infusion therapy. 13 in my book, but I do have, it's 15 in the new book, and I do have one ordered, so I'll get all the chapters updated too, okay? And then I've started putting in my PowerPoints at the end what's expected for you the next week in like lab or whatever, so you know, or what's specific. And then I tried to put like some screenshots so you know where to go too, okay? All right, that's what you look like when you get your first IV stick and it's good, right? It's like, I gotta tell everybody. Right? Don't put anything from clinicals online because that's a HIPAA problem. Okay, let's jump into slide number 2. Oh, I can do this myself. I shouldn't be making you do it. I'm so sorry. All right, let's talk a little bit about infusion therapy. That just means something's going in through the IV, right? And you might hear it referred to as parenteral, and that just means piercing the skin. So when we place that IV, it's going through the skin. That's part of the infection risk, right? We got to make sure that skin is really clean. It's a pretty common way of giving medications in the hospital, and we give IV fluids or IV medications for fluid balance, acid-base balance, and then like blood products, infection, those sorts of things. Oh, what's wrong with There's 3 types that we talk about. IV solutions, so that can also include TPN, which we talked briefly about yesterday. That has to be in central circulation, so there's peripheral and there's central. But then there's IV solutions that we just talked about, isotonic, hypotonic, hypertonic. Usually that's about a fluid balance issue. Too much fluid somewhere, not enough fluid somewhere, right? Whether it's in the cells or it's in the vasculature. Okay, so then there's blood and blood components. We're going to spend just some time today talking about the steps the nurse takes to give blood, because there's quite a few steps to it. And there's things that we're legally bound to do and the NCLEX wants to harp on too, so we're going to focus on those as well, all right? When we talk about blood, there's different components to the blood. There's platelets, plasma, albumin, and then some clotting factors. You might see a patient who has a hemoglobin of 6.4, which is super low. That patient is anemic, right? And then you might receive an order that says 1 unit PRBC, or packed red blood cells. And just for your information, we expect in a healthy body that 1 unit of packed red blood cells is going to increase our hemoglobin by 1 unit, right? So if they're super low, they might go ahead and put in an order for 2 units of packed red blood cells. And in some cases, they might order extra units because they like them a little bit higher. Cases like that would be for our heart failure patients, which we have to be careful giving blood in people who are prone to fluid overload, because we're putting a whole lot more fluid on the body with blood that they didn't have before, and their heart was used to running at the lower rate. And so we can get fluid overloaded with our folks who have CHF or have a heart condition. So sometimes they'll administer a diuretic with it, so they'll pull off the fluid and leave the blood. But you'll have orders for that. You won't do that yourself, but the thought process is you're going to run blood over 2 to 4 hours, right? If your patient is prone or susceptible to fluid overload, you run it a little slower, right? More towards the 4-hour mark than the 2-hour mark. And then drug therapy often goes through the IVs. Those are your antibiotics and such. IV solutions, there's more than 200 IV solutions. And we're going to have a quiz on that next class for all. No, I'm just kidding. No, just kidding. I saw some people look up at me. That was good. You're paying attention. No, we're not going to go over that. We're going to go over the ones that we need to know the most, okay? There's going to be more. You're always learning as a nurse. When you get done with school and you take the NCLEX and you're like, yes, I've mastered it, and I'm so excited for you. Guess what? Then you're going to start learning some more. Because when you get on the floor, you just keep learning. If you've been a nurse for 20 years, you should still be learning every single day. It is a lifetime commitment as part of being a nurse. There are advances in technology, and guess what? Your patients teach you every day too. We're taking care of human beings. It's not just a chart. It's not just a diagnosis. Sorry, that's my soapbox. These fluids are based on their tonicity. You may hear that term some, and that refers to osmolality. Isotonic is iso okay. It's the perfect one, right? The same as the blood, 270 to 300. Hypertonic is above 300. I got a little tip on here, right? So you start getting all these normal salines, different levels, you know? You're like, well, which one is which? A tip is if it's greater than 0.9%, it's hypertonic. And if it's less than 0.9%, it's hypotonic. That just applies to the normal saline. But when you're trying to make sense of one of those 200 IV solutions, any tips and tricks are helpful. Okay. I know this chart is busy, and we're gonna spend a little bit of time in it. And this has some of the information from the video put into one chart. So we have here on the side, we have the types, right? Isotonic, which is I'm so okay, that means the fluid is balanced outside of the cell and in the cell. Hypotonic means what's happening to the cell. Tell me, what? It's swelling, happy hippo, right? And hypertonic, what's happening to the cell? Yeah, so this is just a list of some of the fluids that are isotonic, some of the fluids that are hypotonic, and some of the fluids that are hypertonic. You might see questions where they give you a fluid and a condition and they're like, is this appropriate? And how you'll decide that is to think about what it does to the body and what the patient has going on in their body, right? And then we also have some tips and tricks for that as well. Here we have columns of information. We start with, hey, what's going on in the cell? So this is what's going on in the cell here. And then we give our more examples, and then this is what's happening to the fluid. This is what it's used for. These are things we need to watch out for. So these are problems that the patient could have. And then these are people that we don't use at the bottom. You can't quite see this. Do not use in these patients. When in the video, that feller was talking about ICP, that's increased cranial pressure. We have only so much space up here, right? We've got a skull, it really keeps it here. And when it starts to swell, we start having brain issues. So important to maintain a balance on our cranial pressure. We don't want to do anything that's going to make that increase because then we're going to see some neurological deficits, right? And we can hurt our patient. So if we look at the top, we're going to talk about hypotonic. What's happening to the cell in hypotonic? Talk to me. Fat. We're bringing in the fluid into the cell, right? So cells are going through the vasculature, and that's like a slip and slide, right? We got to have enough fluid on the slip and slide in the vasculature so that they flow, so that they move. And when we get dry, it's harder for it to move. So less solutes than intracellular fluid. We got all the fluid in the cell, right? And then we have our examples. We talked about that. We're going to give a hypotonic fluid for cellular hydration. So we give it for the opposite problem, right? If we know that this fluid causes the cells to swell, we're going to give it to a patient who has dry cells because it's going to help compensate, right, by pulling fluid into the cells. Problems that we're going to watch for are decreased blood pressure, because we're taking out fluid from the vasculature. We're taking out fluid from that slip and slide, right? And so that means there's less fluid going through the vasculature, our blood pressure goes down. More fluid, what happens to the vasculature? It gets bigger, pressure on it, our blood pressure goes higher. Less fluid in the vasculature, our blood pressure goes down, okay? We're gonna watch out, we're not gonna give this in patients with low blood pressure. Why? Yes, exactly, because our slip and slide's getting dry, so our blood pressure's going down, right? So if they're already 85/60, hello, be careful what you give, right? You're gonna have an emergency on your hand. We're not gonna give that in ICP, we're not gonna give that in stroke patients, liver patients, surgery, and burns. Burns especially cause dehydration, so we have to be really careful to make sure they've got enough volume because it's seeping all over the place. Let's go to isotonic. Isotonic solutions mean I'm so okay or I'm so perfect, right? Same amount in and same amount out. We're balanced. We're in homeostasis. We're good, right? We use isotonic fluids a lot in the hospital for fluid replacement. It's used for folks with hemorrhage. It helps in the meantime, right? But we still, if they're hemorrhaging, that means they're bleeding out, they're losing a lot of blood. Some fluid's gonna help that slip and slide, but ultimately oxygen is needed and we're gonna need blood. So you may be giving both fluids and blood, right? But the fluids aren't gonna make it okay. It's just gonna give us a little more time to get the blood in. Diarrhea, if someone's got diarrhea, they've got some dehydration, vomiting, wounds. GI suction is super big. When we have an NG tube, we are sucking out the fluids. We're gonna have electrolyte imbalances and we're gonna have fluid imbalances. So you gotta watch them like a hawk. Watch their labs, watch their signs and symptoms. And the normal saline is the only thing, this is worth knowing, whether it's on our quiz here, I don't remember, but it is something you have to know, and you're likely to see it on quizzes, an ATI, or maybe even the NCLEX, some sort of application of this knowledge. With blood, you can only run normal saline. You cannot run LR, you cannot run D5, it can only be normal saline because it is the same pH as the blood, okay? Good. We don't use isotonic fluids in overloaded patients. You got a feller sitting on the bed, he's got heart failure, his tummy's big, his legs are swollen, he's short of breath, he's got crackles in his lungs, doctor's ordered fluids at 100. You gotta be careful with that, right? He's already fluid overloaded, and that's one of the risks. Whenever we give fluids, it's a balancing act. Do we give too much? Did we not give enough, right? Not enough, and the kidneys are burning too much, and then the lungs are full and we can't breathe. Okay. Hypertonic. What happens with those fluids? What happens to the cells in those fluids? Yeah, they get skinny, they lose fluid, and all the fluid goes out on the slip and slide in the vasculature, right? It's used for hypovolemia, so those folks where the vasculature is dehydrated. So we've got two different types of dehydration going on here. We've got the cellular dehydration and we've got the vascular dehydration. Okay, so depending on what's the cause or what's happening in the body as a result of the dehydration, that's the fluid that you're gonna pick. So we use that for vascular expansion, increase urine output, sometimes for kidney function, and for folks who are third spacing. I want you to write something in on this slide. I can't imagine that I would make you write something extra if it wasn't important, right? I want you to write in there that we're going to give hypertonic solutions for people who are hyponatremic. Hyponatremia is going to have hypertonic fluids to treat it. Okay. So hypertonic fluids brings the water out of the intracellular space. It's a volume expander. and it helps balance that sodium out. Whenever you're giving hypertonic or hypotonic fluids, either one, you got to go slow. The body can't handle too much change all at once. You can throw it into a fit, okay? It can have major repercussions if you're giving it too fast. In this case, if you change your sodium level, we talked about this last week, if you change your sodium level too quickly, what can happen? Seizure. Do you want a seizure for your patient? No, friend, you sure don't. You sure don't. It didn't sound like a good idea. So we're going to make sure that we are measuring our sodium every 6 hours is a pretty standard order. And then if they're going too fast, we're going to back off. You'll see the order change. If it's not changing enough, we might implement another way that we can increase sodium. Okay? I know that's a lot, but it's a good place to start. There's more information than just that, but we got to start somewhere. And this has some of the information from that video summarized in a chart, because you know, I like charts. Isotonic means, yeah, we're balanced, right? That's the chill guy. That's the normal saline. And when we say normal saline, we mean 0.9% normal saline, right? Lactated ringers are also isotonic. They have some potassium in there. They have a little bit of electrolyte balance. You got to be careful when you give that to someone with kidney issues because they don't balance out electrolytes too well. And isotonic, the biggest risk is for overload. Okay, question time. You ready? Assessment. What would you see, hear, assess indicating fluid overload on a patient? Crackles in the lung, what does that mean, Lee? Fluid in there, right? The air running around, the fluid makes it sound like crackles. Good. Edema, someone said difficulty breathing. Hypertension, we got too much water on that slip and slide, right? It's like just flushing it out, too much pressure. Bounding pulse. And where might you see that? JVD. Oh, you guys are good. This is stuff you see on your patients. When you go to clinicals, look for it. We talk about it, that's cool, but you're going to see it in the patient. And it might look a little different from Joe to Nancy, but still you might see those bounding pulses in that increase in JVD. Crackles in lungs, hypertension, increased respiratory rate, right? They're working harder to breathe. And what's the number one way that we can tell that someone is fluid overloaded? What clinical data do we get daily? Yes, we want to check the weight the same time, the same way every day. Good. These are just some pictures of edema. We talk about it, and then I know, that's the face I make too. Imagine if your feet look like that. Ouch, that's got pressure, it's got to hurt. This is the scale of edema. You're going to do assessments every day, multiple times a day of your patients, and you'll be asked to assess edema. For me, I think that, and you may feel differently, but I feel like edema is a lot of experience on whether it's a 1 or a 2 or a 3 or a 4. Sometimes it can go either way. But these are the technical descriptions of what edema means, right? So,
we can bring in. Remember the board that we went over in fundamentals? If you want us to bring that back in on Thursday for you guys to practice
cool.
with.
That's awesome, because you have to do that assessment all the time. All the time. I like pictures of it. No, anytime, girlfriend, anytime. Hypotonic, hypo-hippo, right? It's going to swell the cells. It moves water into the cells and expands them. And those are some examples of the types of fluids that are hypotonic. It's given for conditions that cause intracellular dehydration. That means the cell is skinny and it needs more fluid, so it pulls the fluid in. Okay. Cell expanders. Now, hypertonic is going to be volume expanders. It corrects fluid, electrolyte, acid base imbalances. Water follows sodium, and sodium is now higher in the blood compared to the cell, right? Here's something to know. Write this down. Know this in your head. When we give hypertonic fluids, it causes the cells to shrink at the IV site, right? And that could cause the basement membrane of the veins lining to be exposed, and that puts us at risk at phlebitis. We talked about that yesterday. What is phlebitis? Yeah, so we gotta watch for that because that can make our IVs go bad. Okay, yes ma'am. Shrink. Mm-hmm. Yep. You may have heard somebody talk about TPN. You may have seen it on the floor, or maybe this is your first introduction to it. That's total parenteral nutrition, and that is a way of getting people nutrition who can't take it in by mouth, or they've got some sort of GI issue where absorption is a problem. Maybe they've had abdominal surgery. Sometimes in ICU, we leave people open. We do abdominal surgery and the swelling's too much, we can't close them. So you're gonna not feed the stomach at that time, right? When we talk about total parenteral nutrition, it's important to know about the tonicity of that, and that's measured in the osmolarity. And anything over 600, it's recommended that it goes into central circulation. Right, so a regular IV is peripheral. It starts at one location here, but we need it to go through the heart to get it centrally, to get it everywhere. So you're going to need like a PICC line work. And TPN's osmolarity is greater than 1400. Peripheral line or regular IV just can't handle that kind of tonicity. TPN should never be infused in peripheral circulation and damage the blood cells in the lining of the vein. pH problems. pH is our balance of our body, right? Hypo and hypertonic solutions can cause phlebitis and infiltration. We talked about one causing it, but really any change, significant change from the pH that is regular homeostasis can cause problems with possible phlebitis, which is inflammation of the vein, and that can cause infiltration where the IV solution can leak into the tissues around it. IV solutions have a range of 3.5 to 6.2. Extremes in either direction can cause phlebitis or thrombosis, another word for a blood clot in the vein. Okay, you ready? I'm gonna need your assistance on this.
Okay.
Matchmaker, matchmaker, make me a match. Okay, maybe you've never watched Fiddler on the Roof, but that's an old song. We want to match what's happening to the cell with the fluid that we see here. I wanted you to see pictures of what the bags look like, and there's going to be different brands and different ways, but just so we're starting to get that exposure, because that increases your confidence and helps you connect the dots. We have 0.45% normal saline, sodium chloride, and sometimes we'll call that half. 3% and 0.9%, that's what we call just normal saline. Which one is hypotonic solution? Which one is going to cause the cell to swell? I'll move that over there. You don't have to. I was just going to pull it. Oh, I'm just kidding. We're not going to do that. All right, and which one is isotonic? That's right, and which one is hypertonic? 3%. Yeah, greater than that 0.9, right? Good job, good job. Add that on a whole nother PowerPoint and I reduce things, sorry. All right, let's talk about giving meds. Medication safety is always paramount. It is the priority. Anytime you have an NCLEX question where something's not safe, safety is always the priority, okay? Wink, wink. Medication safety, we've got the 11 rights. They're on the next slide. You need to know them and use them. When I have you in clinical or someone has you in clinical, please make sure you know who that patient is. please follow through and look through your 11. ATI has 11 med rights. IV medications, we talked about this yesterday, has a rapid effect. That means it can have a therapeutic effect right away, or it can have a problem right away. True? Never assume that your IV administration is the same as giving the drug by another route. We talk about routes. We have PO, mouth, we have IM, we have subcutaneous, we have IV, we have rectal. Sometimes you got to do a Tylenol rectal if they're vomiting too much or they've got a fever. So that's important. IV medication takes effect within 1 minute. Usually peak effect is 5 to 10 minutes. So you give that medication, they're going to feel it fast, and then it's going to have peak effect. They're really going to feel it by probably 10 minutes. That gives us a higher risk of reaction. There's your 11 rights. Let's look at it again. Vascular access devices. This is what you use to start an IV, okay? It's a plastic tube like a tiny straw. We got to see that yesterday, at least in the package, and maybe when you were practicing in the arm too. And we talked about some of the different types that we have. It's a plastic, so it has a catheter. That's what's left in place, so not the needle, right? Sometimes that helps patients calm down when you say, hey, I know I'm sticking you with a needle, but I'm not going to leave that in there. You're just going to have a little straw. You'll hear a catheter referred to as a straw a lot, in place so that medicine can get into your vein. So we have the short peripheral catheters, the midline catheters, right? So that's just a longer one, kind of goes to about here. Then we have the PIC, the peripherally inserted central catheters, drops off right above the heart, tunneled catheters, implanted ports, and then we have hemodialysis, which is a whole nother bear. Guess what? We're going to talk about it. These are just some pictures. These are just some pictures so you can see. This is an example of the short one. This is what we use all the time to do the peripheral IVs. And yesterday, you know, depending on if you're at Mercy or if you're at CMH or your Cox, they might have a little bit longer or look a little different. And these are just some pictures of the different versions. I know you've been getting that quite several different ways, but it's handy. Peripheral IV therapy. This is the most common one that we use, right? Okay, short peripheral catheters. That tells you the size. And yesterday we talked about the gauges, right? The gauges. When, if I say 14, is that big or small? If I say 24, is that big or small? Yeah, so the bigger the number, the smaller it is. What's the most common? The most common is a 20, right? And that's what color? Pink. Pink. It's just all right. We're learning this. That's okay. That's okay. All have a safety device. We talked about that. All needles have to have a safety device since the early 2000s. IVs can last 72 to 96 hours, and then they require replacement. It may not last that long. If you've got phlebitis, you've got swelling and pain with flushing, you've got to change it out, right? Because if you don't, it's at risk for the medicine to go into or infiltrate into the tissues around it, and it could cause harm to the patient. And what is paramount? Safety, right? New evidence suggests that you can leave it in longer, and so some places will do that. You can call the doctor and say, hey, so-and-so's discharging tomorrow. Their IV's out of date, but there's no signs of inflammation or phlebitis. Are we okay to keep that another day? You can get a communication order to keep it. This is kind of what it looks like into the vein. I thought that was kind of neat. It's not supposed to be used for blood draws. I talked to my group yesterday about this. ICU sometimes is a whole nother beast. You know, they're going to get blood any way they can get blood. So if it'll give blood, it might. But the risk is that you're going to lyse the cells. You're going to break them down when you're pulling it out. So your labs would be skewed. Okay. These are just pictures. It kind of tells you the flow rate. The group I had yesterday, I showed them on the packaging. It tells how many drops a minute or how many drips a minute it can tolerate. So depending on the treatment your patient's receiving, you pick the gauge or the size that would be most useful for them. You also have to look at their vasculature, right? Some people are a hard stick, and little granny, all maybe I could get was a 22. And that works because she's just getting fluid replacement. But for people who are having larger doses of medication or vesicants that are irritating to the veins, like antibiotics, we might want a little bit bigger, right? And this just goes over. So we look, I've got a couple highlighted because they're the most common. Pink's the most common, and green, go, 18. That's usually what we like to have for blood. You can use a 20 or an 18. And some literature, your textbook says you can use a 22 for blood. And I'll tell you, in the pinch, in real world, you can, but you're at risk for lysing those cells and not having such a good return. Yeah. Okay, I'm so deaf.
Say if you have to get blood.
Yep.
Running the blood at a slower rate. Decrease the possibility of lysis.
That's a good idea.
Increase the possibility of it.
It's not going to increase the probability of it. You even more than that, you got to watch for your. You got to get it in the 4 hours. But yeah, I'd probably turn it down because it's a smaller one. That's a good point. Yeah. If we're pushing it through more quickly, there's more going in at once and they're crowded, so you get a little bit more risk.
Think about that milkshake trying to get a milkshake out of a cotton straw. That's what's happening. And then those blood cells that are going in like this are now being like, so that's what's happening.
The question was there a risk for clotting if, I'm sorry that I'm so old and deaf.
Oh, you're okay. Before slowing down the infusion, is there the clotting of that blood?
I think you're okay as long as you're in 4 hours. It's still moving fast. It's a good question. I see that thought process of, okay, if the blood's sitting there, it's more likely to congeal and have problems. But it's not really sitting, it's still going. So good thought process, so I see where that's coming from. Good. Such a good, thoughtful, critical thinking question. What size should I use? This just gives you some tips for what size to pick and why. Again, I'm kind of that practical person, right? 18 gauge we use for trauma, surgery, blood transfusions, and for CT scans with dye. You got to have a larger vein. 20 is the most common. It's suitable for non-emergent blood transfusions. When you have an emergent, meaning right now I need it, transfusion, you run a little faster than you run it when it's like on a MedSurg floor or not an emergency situation. 22, older adults, suitable for slow speed infusions. And 24 is a lot of pediatric. Sometimes same day infusions will use 24 if they go to get a site selection. This is important information, stuff to know. Avoid the risks. Be careful with where you don't want to hit the bone and there's the nerve there. You still could have it like right here. And yesterday she talked about you got a lot of arteries right here, so you want to go down a little bit. We want the IV to be in a vein. 2 attempts per person, 4 total attempts, then you got to call in the big dogs. A lot of places will have a special team. Smaller the places, not as likely. Overnight, hello. We have a PIC team at Cox. There's a specialty team that has an ultrasound, which lets you tell, where the vein is and how deep it is, so that they're more likely to get a stick. Or then they use that also for their PIC line placements, their midline placements, and that's super helpful. I know at CMH they can call and have some folks come with a vein finder or an ultrasound as well. But you always want to be able to, it's a matter of pride, really. You want to be able to start your own IV. But sometimes you got to phone a friend. We got some folks on our floor who are super, used to be phlebotomists before they were nurses, and they can really get a stick when you can't. Sometimes I'll trade. I'll be like, I'll pass your meds if you'll get an IV on 30. Use your resources as well. useful. And then that's more common on night shift too, like that PIC team goes home and you need an IV to give IV antibiotics and it went bad at 12 o'clock and your IVs due at 2, antibiotics due at 2 in the morning. Well, you got to get a stick, right? You got to get that done somehow. Veins cannot be used on the side with a mastectomy or a lymph node dissection. Lymphedema, that's a picture of lymphedema. Don't put it, you know, with the dialysis graft or fistula, put it away from that. Watch out for paralysis. You can use those vein eliminators or the ultrasounds that we talked about. You have an ATI sheet that tells you the steps for doing an IV. That's the end all be all for us. The ATI tells you. There's about 75,000 steps. So sometimes my brain with that many steps gets lost. This is a 10-step summary. You're ultimately responsible for the ATI version, okay? But this sometimes helps with the starting point, right? These are the steps for getting an IV. You know, steps, verify order for an IV, ADET, verify patient and allergies. And sometimes that order is implied. If it's a power, you know, we have like at Cox, we'll have a power plan and it'll say insert IV, that counts as an order. But if they order a medication that requires an IV, that counts as an order, okay? Supplies, you've got your alcohol wipe, your chlorhexidine wipes, those are better, makes the vein stand up a little bit better than alcohol wipe. Gloves, tourniquet, your actual cannula, 18 or 20 is preferred, the J-loop or PRN adapter, flush, the Tegaderm is just the sticker that goes on the top, it's the tape. Sanitize your hands, apply a tourniquet, and assess for the best vein. Yesterday I had my folks feel my veins real bouncy. Veins are bouncy or spongy. And more important than what you see is what you feel when you go to do an IV. Put on gloves, clean the patient's skin, let it dry. Don't blow on it, friends. I know it's habit, right? But you blow on it, whatever germs are in your mouth, past your coffee, is going right on that skin. It's not clean anymore. Remove the cannula from its packaging and remove the needle cover. Don't touch the needle. Insert the needle bevel up until a flashback of blood is seen in the hub at the back of the cannula. That's what the picture is showing. What's the picture showing? A flash, right? Advance the entire cannula a bit further, then fix the needle and advance with the catheter into the vein. Release the tourniquet, apply pressure to the vein at the tip of the cannula up top, remove the needle, and then connect your J-loop. So sometimes when people first start an IV, it's hard to get your hands right where you need to be. Correct me if you have difference of opinion. It's hard to get your hands where they need to be to hold pressure so that it doesn't bleed through the catheter as you connect the PRN adapter or the J-loop. I always put a towel down first. If you have a little bit of blood, they're not going to bleed out. You're not going to take 18 years to connect it, right? You just don't want to have to change the bed. I'm going to help you connect it, right? So that's okay. Yes.
Actually stick on the bone. You just find the vein. Right? That's what
After you get a flash.
Essentially, and what she was referring to, I wasn't in there, so I'm not for sure. But what can happen is if you have an older person, normally with an older person, you can see their veins, like, oh man, that's a real good vein. So what can happen is if you stick them with the tourniquet on, bam, you blow it. Okay? So the ones that you have to, for instance, if you were going to get an IV on me, you will want to tourniquet me and stick. If you're looking at an older person, you want to tourniquet, find it, undo the tourniquet, and then stick because of the chances of blowing a vein. So let's say you blow a vein the very first time. If you are with any of us in clinicals, we're probably going to be like, oh, hey, next time, let's not use that tourniquet because we don't want to pop that. So that might have been what she was referring to.
She's giving you tips and tricks for how to handle the specialty cases. And then apply the dressing to the cannula to fix it in place and ensure that the date sticker has been completed and applied. And you'll see that in your packet that you have. I just want to make sure that you know the main steps for it and that you know that flash is super important. The flash means that you're in the vein. If you didn't get a flash, you didn't get the stick, right? Okay. Infection control, what did we say is paramount? Safety. Your hospitals, your facilities. Infection control is huge because it's a matter of safety for your patient. The CDC recommends aseptic preparation and technique when placing an IV. That's why you clean your hands and put on gloves. Some of oh, I don't mean older people. I mean, some of the more experienced nurses sometimes rip out the finger on their glove. My friend Amy does that all the time. You're not supposed to do that, okay? Because what's on your finger, who knows, even after you clean it, right? Be careful. Aseptic technique means the absence of bacteria. Watch your lines, tubes, and drains. When I get my folks in clinicals, I say part of your first assessment is check lines, tubes, and drains. You walk in the room, do they got the nasal cannula in their nose or is it hanging down on the floor? Not doing any good to give oxygen to the linens, right? It's got to be in the nose or maybe in the mouth. We can talk about that later. If they got a Foley, is it up by their head because it's not draining, right? You know, they got some sort of lines, tubes, and drains. Right? They got a JP drain. Is it full and not pulling any more out because it needs drain and pushed down? If you come into a room, I'm going to ask you a question. If you come into a room and the end of the IV is not capped, it is dirty, contaminated. What are you going to do with that line? Get a whole new one. Don't try to alcohol swab that, friend. Right? Best practice is to get new line. You're going to do the medication and you've got that tip. Yesterday in lab, I was like, we're watching it like a toddler at the park, aren't we? We got to watch it. Make sure that it doesn't get dirty, contaminated, because we're just introducing that bacteria straight into a vein. These people are already sick and they're not going to have IV medication, right? They can't tolerate a whole lot. We got to protect them. That's our job for safety. It drops on the med cart and I'm got a few choice words in my head, but I got to get a new line, right? Okay. Good. That's important. Midline catheter, that's an extra long IV. It still go in your AC space, and then it's just got a long piece. That's used for folks with poor venous status, heart sticks. Maybe their IVs don't last very long. Maybe they're a little bit bigger and their veins are a little bit deeper, so we end up putting in the midline. Maybe we tried to do a PICC line and we couldn't get it all the way, so we pulled it back and left it in the midline. It's usually 3 to 8 inches long, and it says, hey, the catheter size is 3 to 5 French. FR means for French. Where that means it's going to be from this size to this size in the vein. I thought it was kind of neat to see a picture of what it means when it says, hey, that Foley is a 16 French. That means this is the size of the catheter going in the urethra, right? And then this is 3 to 5, and then the PICC line will be a little bit bigger. Couple things about that midline. Go back. It's a single lumen, means one ender, one thing to put meds in, and you need to make sure that the meds are compatible because there's only one lumen, there's only one end, the meds have to be compatible, okay? And you're not technically supposed to use it for a med draw or a blood draw, but what did we say about ICU? You're gonna get blood the way you're gonna get blood, right? So you might have different protocols on your hospital than what I'm saying. I thought this was so neat. Sometimes I'll have to place an extra large Foley. I'll just hurt for them. Central IV therapy, that means that the tip is going to be right above the heart at the superior vena cava. It's going to drop right here. And then it goes through the heart and into central circulation, meaning all through the body, right? It's not just a localized area. So the risk is higher, right? If we're going to have a reaction at the site here, or we're going to get infection at the site here, that if we catch it soon enough, it's not going to go to the heart throughout the whole body. If our PICC line, that is a central IV, gets infected, it's likely to go through the whole body, right? It's a bigger infection. We talked about that. Blood flow, you can do 2 liters a minute. If I had to, if you got to do some major resuscitation with hydration, this is the way to go. So you'll see a lot of your very sick patients having this. You cannot use it until you have confirmed placement. It's got to be in the right place to use it or it can hurt your patient. So you absolutely have to have an x-ray to confirm placement before you use it. What do you have to do before you use it the first time? Right, you got to confirm placement with the chest x-ray. Good. This is also important. You'll have a ton of health streams on this. Infection from a central line is referred to as a central line associated bloodstream infection, and nobody wants to say that, so they say CLABSI. It means the hospital doesn't get paid. It means your patient's going to be there longer. It's going to cost more to take care of them, and they have a higher mortality rate. It's bad all around. It's bad for the hospital's bottom line, but ultimately it's bad for your patient and their safety and their health. PIC. What does PIC mean? That's the shortened version. What's it stand for? Peripherally inserted central catheter. That's right. And what determines placement? Right. And it can be 18 to 29 inches long. Sometimes you'll see it listed in centimeters, 45 to 72. At CMH, they do a real good job of putting a sign above the bed that'll have the length on it. One of the reasons that's important is because when you take it out, you want to make sure you got the whole line. If we have a piece stuck in there, we're going to have a bigger problem. A bigger problem. PICs are used for contrast injection, CVP monitoring. We'll talk a little bit about that in a bit. It's available in single, double, and triple lumens. That's the end of the line, has different places to insert medication. That's what the lumens are. There's no limit on our pH or osmolality. So we were talking about, hey, IVs can only handle 600 peripheral IVs. This doesn't matter. You can put TPN in here and it's over 1400. It's in a big enough vein that it can tolerate it without it being a vesicant, without it being such an irritant to the vasculature. Blood draws are okay. At Cox, you have to have an order because of risk for clots when you pull back, when you pull blood out. You flush with 10, you waste 10 mLs of blood, then you draw the blood, and then you flush with 20. You want to highlight that. That's the process for pulling blood out of a PIC. You have to use a 10 ml flush with a PIC line. Don't use a 5. It's not enough pressure. Whenever you're dealing with a PIC line, you have a pulsating movement because that helps knock off fibrin that may be building up at the tip, which is a precursor to a clot. Assess your PIC line before you give medication. Every single time. I know you were in there and you gave meds 2 hours ago. Every single time you give medication in a PIC line, because it's such a risk for infection and a type of infection that can really hurt your patient, assess that PIC line. You're looking for phlebitis or inflammation. You're looking for redness and pain and swelling. You're checking the dressing for blood loss. All right? A little bit of blood is expected. Too much blood, we need to change the dressing. Depending on where you're at, you may have to have special certification to change that dressing. Sometimes they have a special team that do it. Ultimately, a nurse, an RN, is qualified to do it. However, some places have protocols where they have specialty teams because the thought process is, if I train these people to do tasks that are more likely to infection, then I'm reducing risk for infection for my patient population. And those CLABSIs, we don't get paid, right? So sometimes that's why they have these specialized teams. I think we talked about this yesterday a little bit. And the smaller places don't. The bigger places sometimes do. Look for, these are the things you're looking for. You need to meet this criteria before you give a medication. This could be important. It needs to be intact. Patent, what does patent mean? We talked about that yesterday. Usable, open, it flushes. Good blood return. Site's clean and free of any signs of infiltration, infection. This is the expected finding for a PIC line before using it. If you see that it meets all that criteria, go ahead and use it. If it doesn't, then we need to call the doctor and see if we need to get a sample, if we need to check to see if it's growing any bacteria or if it needs adjusted. Okay. Yeah, I'm sorry, I'm just getting excited. I really like this stuff. Oh, I suppose you'd like a potty break. Let's do a 5-minute break because we really need to get a bunch in. Can you handle that? 5 minutes, which means 10:01. 10:01. Come back at 10:01. We got lots of fun stuff to talk about. I know. I'm excited enough for both of us. It's all right. Oh, I gave you a headache.
No, my other tooth is now hurting.
No. Yes. And I'm going to show you.
It's on the notes if you pull up your PowerPoints on your computer.
Or if you print it where the notes are shown, or you can like, when I was in nursing school, I would copy the notes from the PowerPoints and just make a Word document so they were all in one place. Sometimes I'll put information below the PowerPoints that help explain it more or give lists or help point out some things. You go to, you print it singly. So you go to print a slide per page notes version. And that's how you do it. And that's why sometimes when I was in nursing school, I would just copy the data and put it all in a Word document.
Wait, save your print.
Save your print, save your paper. And you kind of have like a little review all in one place. And I'm usually pretty good about leaving extra notes with the slide.
Yeah, when I was going through for the test, they had a lot of information.
They just have, and I'll try to point out things as we go too. Things that are practical. We're not just taking, we've got to have information that's for this class and passing this class, but also taking care of our patients and passing the NCLEX. So not all the information makes it on the quizzes or the tests, but it still may be very useful for you to know. And I try to focus on the most useful information. There's a lot in MedSurg. There's always more, but you got to start somewhere. Which one?
At the end that was needed.
Yep. Expected findings. The PIC is going to be intact. It's going to be patent. It's going to have blood return and free of any signs of infection or infiltration. Those are expected findings, and that means you can use it.
I have a question about the infiltration. Is it like the same as before?
Yeah, that's a good question. It's a little deeper, right? So usually for PIC, they can migrate. So they can go far into the heart, and then they can have a regular rhythm on your telemetry because the heart doesn't want a little tube stuck in, right? Or it can be too far up, and it's more of a midline, and so you can notice some irritation there, or some flow issue like obvious blood return, and you might need to do another X-ray. Yes. Yeah, that's what I and then the flow rate. It is a little harder to assess. It is probably yeah. Well, and I guess mostly that means moving out of those things. You want to arrive on this because we get things that have and that's hard on the vascular they tolerate that. It's like 2 gallons of urine in a tub, 2 gallons of each in a lymphocyte.
I know. I'm very really good. What if so many more questions?
I'm not gonna do all of them.
Don't we have another PowerPoint too?
It's 10 slides though. It's not bad. And it's the blood steps. So it is important. And it is testable material and it is stuff you will actually use, but we'll get to it. We probably won't have time. I would use them on my own time because they highlight certain information, but also it practices using those NCLEX type questions. You know, the farther you get through nursing school, the more of those questions you see, and getting your head wrapped around how to think to answer them is a big part of passing the NCLEX. So practice, practice, practice.
I have a question.
Yes.
Okay, so lifelines and central lights are going to
I'm sorry,
lifelines and central lights. Right, so why would I create a line? Or you have to be within one line? I just wanted to
Yeah, that's special training to do that. So we have nurses. I don't think they have special training. I just thought that it was just an extra.
See that? Great rhythm.
Somebody tell me what's next.
What do you say we hit it hard so we can get out of here? Are you up for it? I know we get a ton of information. What? We still got a lot to cover. Oh, I have no control over that. I'm a peon. I got.
Not much. Then they're gonna run the roads. Then we'll let you know.
Okay, I'm gonna go ahead and get hopping if that's all right with you folks. This is just some pictures. You know I'm big on pictures because it helps you understand the material, apply the material in your head. This is a PIC line. This is a triple lumen, right? 1, 2, 3. Shows you where it goes in. You have to flush it with what size syringe? 10. And then what type of motion? Pulsing. So that you can avoid this fibrin sheath. That's the precursor to a clot. I thought it was neat to see how it looks, right? That's the start of a clot, then it turns into, then there's different types of clots. And this is an example of what the PIC line can look like and where it comes out at. And this is what type of PIC? 1, 2, double lumen PIC. You got it.
I do have a question. You said the midline catheter is only if you deliver it, but on the slide it says it can be a double warranty. That's accurate on the slide, or?
Where does it say that?
The first line is 3 to 8 inches long.
Oh, it does. So that would be really special. I will modify my statement. It is typically a single lumen. So if they were trying to do a double lumen PIC and they pulled it back and left it as a midline, but you know, they can change out those ends too. They have to be specially certified though. Okay, non-tunneled percutaneous central venous catheter. What a big mouthful, right? And it's still going, you know, it's going right there. We're still getting it towards the heart. That's what makes it central venous, right? That's what makes central supply. That's why we can run more things through it at a higher rate. That's why we can run that TPN in it, which has the high osmolarity, the high tonicity. It's inserted through the subclavian vein in the upper chest or the jugular vein. Again, you usually have to have some special training before you do that. But you'll see this in some of our trauma patients that come in through the ED, and sometimes, usually it's trauma patients, or people are super sick crashing when they arrive. Insertion's done by a doctor, a PA, or an NP. This is different than the PIC line. Okay, may require insertion in the femoral vein. Where's that at? What's the big risk of that?
Infection.
Yeah, you almost can't keep that clean enough. I don't care what you do. I don't care if you tape it, cover it, pray about it. You almost can't keep it clean enough. It's a huge infection risk, right? May require insertion, high infection risk. Get it out as soon as you don't need it. As soon as you don't need a central line, you need to have it removed. Emergencies, trauma, critical care, it's usually 7 to 10 inches because we put it so close to where it goes. The tip resides in the superior vena cava, just like with our PICC line. And we still need a chest x-ray to confirm placement before we do anything with it. You gotta make sure it's in place before you do anything with it. It's safety. There's no specific dwell time as far as how long it can stay, but it's usually a short term. It's usually because of acute condition, meaning super sick.
So is that the same as like an IJ? Like that term was like used all the time.
Yeah, it can be. And this is just, hey, here's the subclavian vein. Here's it, IJ. So that's where you would see them go in. They would have the little dangles hanging right here. Don't think about turning your neck, and that bandage can get all messed up. They sweat. Here. Another type of central venous catheter, the common denominator is it goes into the central supply of your blood system. It goes right above the heart. That you can use more vesicants, so you can use higher amounts of fluids, and you can use more things that are irritating to the veins with less risk. But anytime you have a central catheter, there's a bigger risk of infection, right? Portion lies in the subcutaneous tunnel, creates a buffer from outside organisms. That's the benefit of the tunnel. See, it goes through the skin and then goes in and down, right? It's used for frequent long-term infusion therapy. Sometimes cancer patients have this. They don't want a port because you don't have to keep getting stuck. But then you have to keep it clean when you go home. So there's pros and cons to both sides. And it can have multiple lumens, and those are some of the brands that you'll see. An implanted port. We felt that yesterday on the chest, right? We talked about a simple port and a power port. Simple ports are often circular. Power ports have the 3 dots that we felt. You have to identify it by 2 different means. So you can use a palpation assessment, but it also has to be either in the chart or noted somewhere. Sometimes the patients have a card with them. That's what the textbook says, that these patients have a card. None of my patients has ever had a card with them when they're in the hospital. So you have to go through the electronic record to find it. I'm sure they exist. They tell you, oh yeah, I have that card at home. You gotta find another way. We can't just tell you they got a card, right? Upper chest, it's not visible externally, but you can palpate it. We talked a little bit about bigger people like me. Sometimes it's harder to palpate, but lots of times it's for cancer patients, and the side effect of chemo is what? Weight loss, nausea, vomiting, anorexia, in the sense that they're not eating anything, so they can get really skinny. You can really see it at that time. It needs to be heparinized between uses and monthly when not in use. Here's the thing, as a nurse, let's say you've got the patient's getting ready to go home and you're going to de-access that port. It's got a needle in it, so it's risk for infection. Anytime we got poke in the skin, it's a risk for infection. So I got to take that out, right? So I take it out and I realize I didn't heparinize it before I de-accessed it. You have to re-access it, which is a sterile procedure. Confirm that you can pull blood from it, put heparin in it, and then de-access it again. If you don't do that, then the problem is it could go bad, right? And you do have to have a doctor's order for heparin. It's not just something you can pull and give. Okay? Some are PowerPoints, some are simple, and the PowerPoints can handle a higher rate of infusion. So like if they're getting an MRI, it has to be a PowerPoint. Sorry, I'm just going back. That's in a picture of it. And that's one of the, this is a power port that we saw. This is an example of the steps for putting it in. So hemodialysis. Some of you may end up being dialysis nurses, and God bless you. I was interested in that because it has so much to do with fluid volume, fluid volume overload, also with electrolytes and shifts in fluids. And it's so interesting, and they have extra leeway, if you will, to titrate within an area. So you have to really know your stuff to do it. But it's the same thing over and over and over. So if you need some variety, once you got it, you got it. So on MedSurg. Large lumens to accommodate hemodialysis. That's where we take the blood out of the body, we put it through a filter and put it back in the body, and it takes out the waste products that the kidneys are no longer filtered. It's at risk for catheter-related infections. It's a big deal. It's a big deal. You got to watch out. Do not use for administering other fluids or medications. Don't put your IV fluids through the dialysis port. Okay? Just in general, don't do that. And they're going to look a little different. See, their tips look different. Their tips are going to look different. And usually we've got a label on it. Heparin or sodium citrate is used to prevent clotting between uses, and I have to aspirate that out. There's 2 ports, red and blue. Red for arterial, blue for venous. Okay. Just don't put your medicine through a dialysis port. Okay, got it. Okay. Okay, and sometimes if they're long-term dialysis, your patient may have a fistula. And those are really neat in clinicals to see because you can palpate them and you can auscultate them, right? If you, and this is an example of what a healthy fistula looks like. It's a mixing of a vein and an artery so that when they access that, it's a bigger flow, a bigger area to put blood in and pull blood out, right? And down lower in this PowerPoint, I have some just extra information. And there's a picture of how they access it, how it works, if you're interested in that. You palpate it for a thrill because the flow is going so fast. When you gently press on it with your 2 fingers, you feel that. You feel that whooshing by, and that's called a thrill. Don't put an IV in the arm with the fistula. Don't do blood draws in the arm. Don't do a blood pressure in the arm. And you assess circulation to distal, below it, okay? There's a cool little video there. We don't have time for it, Doug. There's a cool little video there that shows you how they make it. Fistula, it's a merger of an artery and a vein so that they can have hemodialysis when they have it regularly, maybe 3 times a week. Lasts more long term, but it takes like a year. It takes some time to mature. It takes about 6 weeks, and sometimes they wait even longer. It does. Yes, yes, yes. Artery and vein stitched together so that there's more blood flow in one spot to pull out, go through the dialysis, and come back in.
And they go to the heart or from the heart?
Both. They're surgically put together. Oh. Maybe I need to show my video after all. If you just go down to the bottom of the PowerPoint.
Here you go, guys.
I was thinking that you were like taking the artery and attaching it to the vein.
Oh, yeah, no, so it makes it more strong because dialysis have that
Flow. It has mixed blood. They do mix. They do mix.
push rule. What are you? Is that what you're talking about?
Hey, why don't you play that video?
What's it? What was it? Like a skin, well, layman term skin tag.
this is just, that's what it sounds like when you auscultate it. That mixed flow that they have together, it sounds like that. Sorry. I wish you were video I thought. Okay. Come on back, sister.
Watch NFL games
That
live.
was it.
But that's why I thought it was at the same time.
All right, next slide, Johnna. Infusion system are pumps and pieces, the things that we're using to get the medication from the IV bag into the body. Containers could be plastic. Yesterday when we had those bags, those were plastic. Sometimes you'll have glass, and you know that has to have the venting. Often things that might be glass would be like albumin, which is protein in the blood. Helps with like balancing your blood pressure. They've got third spacing because it helps the fluid stay in the vasculature instead of flowing out to the tissues around it. And other times you'll have IV Tylenol, because we found with studies that Tylenol given IV after surgery helps reduce reliance on opioid medication. So there's less risk of like respiratory decline after surgery if you're using IV Tylenol. We talked about primary tubing and secondary tubing yesterday. And we talked a little bit about the Luralock. They used to throw that term around in nursing school, and I don't think I knew what it was. I used to be a psych tech before I was in nursing school, and before that I taught English. So I didn't have a whole lot of nursing background, and they just throw that term around, and I just knew what it was. And I was like, what in the world is a Luralock? This is an example of a connection that's a Luralock. Yeah, it sticks together and turns together without using a needle. Change blood at 4 hour tubing information. Change your tubing with blood after 4 hours and lipids at 24 hours. So like your TPN has lipids in it, so you have to have new tubing every 24 hours. Because those lipids can grow bacteria like nobody's business. And it causes infection, and safety is paramount. These are just pictures of what each thing is. That's the primary. You see primary and secondary are piggyback. Pumps. Oh, yesterday, wasn't that fun with those dial-up pumps? No. But, so there's different types of pumps that you'll run into depending on where you work, and you'll learn on site. But it's important to kind of know they'll give you prompts that you can follow, and until you hit start, you haven't hurt the patient. Oh my God, I put in 1,000 and I meant to put in 100. Clear that puppy. Check it before you hit start, right? And fix it before you give it to your patient. We talked a little bit about syringe pumps yesterday. I love syringe pumps. So instead of having your medicine in a bag that's flowing, it's usually a little bit of medicine, 10 or 20 mLs, and you pull it up in a syringe, and the syringe pump pushes it very slowly. Whenever I have medication like Lasix or furosemide, that's a diuretic, it can cause ototoxicity if you push it too quickly. It can be hard on kidneys. So our patients that have cardiorenal syndrome, or they have a bad heart and bad kidneys, or just bad kidneys, and you got to be really careful how you push that Lasix, because you can hurt it further. You can make them irritated and not work as well. So you want to push it slow. When you get to the bigger doses, it's even more important to push slow. I pop that. If I got an 80 dose of Lasix, I pop it on a syringe pump and run it over 30 minutes, because that goes in slowly and it is better tolerated by the patient and puts them at less risk. Now, in my place where I work at Cox, it's within protocol for me to do that. So the answer is always going to be depends on your facility. But yeah, we can do that because it's safer than if I push it. And then I'm not trying to push it over 2 to 5 minutes at the bedside. Really? No, don't. Just with blood. Some medications, so like pain medication, if I'm given, I got a PCA pump, so that's the pain control pump, then you're gonna have to have 2 nurses. Any of the high risk medications, you'll have to have 2 nurses. This is good. That means that if they're on an insulin drip and they're on a glucomander, you gotta have 2 nurses. Heparin, you gotta have 2 nurses. So on my floor, we run insulin drips, we run heparin drips, we run amiodarone drips. And if they're high risk, then you have to have 2 nurses. Correct. Correct. Good question. That was a dumb question. That was wonderful. Those are just some different pumps that you'll see. These are like self-infusing. Sometimes you see them at long-term care. Sometimes people go home with them. I haven't particularly seen one. I have to look it up. Cancer patients have them too. Nice. So they get a little antibiotics. Nice. So these couple slides are important information too. I know, right? Bad things can happen if we don't take extra care of our IV sites. Anytime we puncture the skin, we're at risk for infection. And these are just some pictures of it. And then there's all these different terms that describe damage that can happen. So infiltration is leakage of a non-vesicant. That's the key term for infiltration. So a non-vesicant would be something that has the same pH as the blood. So that would be our, what type of fluids? Normal saline, and that is what type? Isotonic. That's very good. If we see that we've got some infiltration, then we are going to stop the infusion and remove the IV, because what's paramount? Safety. When you get stuck on some of these questions, in CLEX questions, test questions, think about what's the safest for your patient. And then there's extravasation. I said that perfectly. That's leakage of a vesicant into the extravascular tissue. That might be like an antibiotic. That could cause some tissue damage or maybe some nerve damage. So it's really important to watch for that with our vesicants, our antibiotics, so that we can stop it as soon as possible. Stop infusion and remove IV immediately. Phlebitis and post-infusion phlebitis is inflammation. Remove it and put on warm compress. Inflammation, warm compress helps it absorb back into the vasculature. Thrombosis, thrombophlebitis is a blood clot in the vein. Stop and remove IV, and then you put a cold compress on it and elevate it. So how do you confirm, you suspect, but how do you confirm that there's thrombosis, that there's a clot? Call the doctor and ask for what? Who said? Yes, an ultrasound, so you can see if there's a clot. Some clots are what they call superficial, which means it doesn't block the flow, and some of them are occlusive, or a deeper vein issue, and that puts them at risk for what? Where can clots go? Yes, yeah, I saw you pointing, that's right. It can go to your head, which we call stroke. You can get a clot in your heart, affects your pumping of your heart. You can get a PE. My goodness, 30% of people, their first sign of a PE is sudden death. We see so many PEs in the hospital that I can find myself not realizing how significant that is, but it really is. 30% of folks, their first sign or symptom of a PE is sudden death. I've seen it. I've seen it with the patient throw PE. She was an RN. She was sick with COPD, other issues, sat up at the bed, talking, gasped. She got through a PE. Yeah, you know, yeah, you remember. We work on the same floor. So it can go there, it can go in your leg, right? And the risk of the leg is that it can shoot up to the heart. So it can be one other place, break off and go somewhere else and cause even more damage. Our treatment for clots is an anticoagulant, because once you have one clot, you're at risk for more clots. So we're not going to lysis those clots unless they're a big risk, because of the risk of what they have to do thrombolysis, to pull it out, to break it down, right? With our strokes, if it's in a certain time frame, we can do TPA, and sometimes they'll go in and strip the vein, sometimes they'll go in and administer a localized TPA. Yeah. Yes. So what they'll do is, good question, by the way, that's good critical thinking. Yeah, so once you've got a blood clot, you're going to be on an anticoagulant. The gold standard right now is apixaban or Eliquis. We'll get into that some more. And it's for 6 months. You'll follow up with your pulmonologist if it's a PE, and they'll do a repeat scan to see that it's shrinking over time. Usually they try to wean people, but if they get a second one, then they're on it for lifetime. So the doctor will decide how long that therapy is, but it is something they go home on anticoagulant therapy for a clot. Good. Good questions. What's ecchymosis mean? Bruising, right? IV, we can see some bruising, especially if they're on a heparin drip. Bruising everywhere anytime you stick them. Good, good, good. Know that slide. Local complications. What's a hematoma? Yeah, I heard it. So results of uncontrolled bleeding, and we get a big pocket of blood somewhere. Man, be careful with people who have cardiac cath procedure. Sometimes they come back to the MedSurg floor, right? And they go in through the femoral. Sometimes we do the arm now, but they go in through the femoral. You gotta palpate that to make sure there's not a big knot underneath it, because that knot can be the formation of a hematoma or a collection of blood. And depending on how much blood they lose, they could be at risk for like anemia, or we need to get that blood stopped, right? So that's part of your assessment after a cardiac cath. No, that's not on the test. It's just good information. Site infection, clean site with alcohol, drainage, and they'll send that tip for culture. She talked about that yesterday. I've never had a snip tip like that before. I've always had people come do that, but that's pretty interesting. A venous spasm, that's the sudden contraction of a vein. It's painful. Turn down the drip. This happens a lot with potassium. Oh, I said that really country. With potassium, because it's a vesicant and it makes the vein spasm. So you turn down the rate or you increase the amount of normal saline with it. And you can sometimes even have nerve damage with some of the complications of IV therapy. So basically, if there's a problem, you stop it. Okay? If the IV is compromised, you remove it. Okay? General rule of thumb. Systemic complications. So before we were talking about localized complications of the IV, right? Now we can talk about it can get bad, friends. It can get bad and affect the whole body. Circulatory overload, that means that we got too much fluid and the body doesn't know what to do with it. And so we start to see signs and symptoms of fluid overload. And we need to slow the IV rate, notify the provider, monitor vitals. And in some cases, you'll hold them depending on how severe the reaction is. You always have to notify the provider, but that's not what you do first, right? When you're trying to tell what do I do first, what is the safest thing to do? Stop the fluids, right? Because the fluids are causing the problem. And then you have to notify the provider because you can't write an order for that. You need them to do it. Okay. Speed shock, systemic reaction to a rapid infusion of a substance that they're unfamiliar with. You'll stop the infusion and then you'll usually get an order for the fluid balance replacement. What does KVO mean? What is the typical rate that we use for KVO? 10 to 15 is the textbook answer. You'll see people at 30, but some of our fluid overload people, they can't handle 30 an hour, even that. So 10 is the rule. Sometimes you'll see it at 15. We talked about a little bit ago that if a piece of that catheter, when we take the PICC line out, we want to make sure we've got the full amount of it came out of the body, because leaving some of it in there can make for a big problem. One of those big problems is a catheter embolism. That's where a shaving of the catheter comes off and it's free in a vessel. This is an emergency. I don't really see it a whole lot, but it happens. It happens. Notify your provider, put a tourniquet above the IV and inspect the catheter to determine what amount was lost. And they may have to have surgery or an x-ray to find out more information. Catheter embolism, signs and symptoms, anxiety, pallor, cyanosis, that's blue around like your lips, shortness of breath, weak pulse, hypertension, it's blocking off some of the flow, okay, chest pain. Our older adults need a little different type of care sometimes. They're a little bit more fragile. Their body's been around a little bit longer. Usually their kidneys don't filter as well. Sometimes they have heart problems. They're at risk for having more complicating factors, right? Comorbidities, other health issues. and their poor skin, right? We talked about skin last week when we checked for tinting on older people. Where do we need to check? Yeah, a couple different places, but not the hand. The hand goes first. We lose our elasticity in the hand first. Those loose, fragile skin, they're at risk for tears and cracks. Even when you take off an IV, I've seen someone take out an IV and take that tape off and just have a huge bunch of skin come off. So if we need to use a special Tegaderm or special tape, make that consideration before you place it. If you're the person that's taking out that IV, be extra careful. Sometimes you can't help it. But because those skin tears, they also don't heal as fast, right? So it can be a bigger issue for them to have a skin tear than a 20-year-old having a skin tear. Try to avoid the veins on the back of the hand because it's so superficial at that point, they can burst easily and have complications that we talked about earlier. You sometimes have to protect your IV from confused patient. Pet peeve. Sometimes people wrap their IV with Coban. If you wrap that IV too hard, you're going to cause damage. You got to be careful with what you do. You can secure it and you can wrap it, but you got to be careful not to cause damage to the patient. If it's super tight, what's going to happen to the skin above and below it? It's going to swell up, circulation's going to be compromised, plus we're pushing that vein down and we might have compromised our IV with that constant pressure, right? So be careful with that. So they have protectors that you can wrap around that are harder material. I've used an ACE bandage before because it's a little thicker, and Coban over time gets tighter. And you can use some if you use it loose enough. But you just got to be thoughtful of what am I going to cause? Am I going to cause any damage to the patient's skin or circulation? And that's a big deal. And if you come on shift and they've got something wrapped up, you need to unwrap it and look under it. You're a curious cat, right? You're responsible for that patient. That means you got to assess. I know that means you have to rewrap it. I know that it was there before and it was doing a good job, but who knows what's happening under that bandage unless you look, right? I got all kinds of soapboxes today. Alternative sites for infusion. Most common are like the sub-Q infusions. Somebody talked about like a insulin pump yesterday. That's an example of like a subcutaneous infusion. You have a spinal, an epidural. So sometimes after surgery, like for our folks that have a thoracotomy, that's where they take off a piece of your lung, a section of your lung. We'll often have an epidural. Big thing for that, practical information. Don't let it go dry, because then they got to go back to surgery to get it primed. It's pretty hard. It's going right in your spine. So be careful with that. Don't run it dry. IO, intraosseous therapy. Has anybody seen an IO? We talked about it yesterday. Yeah. So that's where they drill into the bone. And this is, when you see this happen, your patient's in bad shape. It's the last ditch effort, right, to get fluids in or whatever. Don't use it long term. It's usually an emergency, trauma and burns. I had a patient when I was on orientation as a new nurse. It was Saturday, so we didn't have a full staffing, real world here. So lots of patients, real busy, our floor's busy. And my patient was in with CHF issues. He'd had a AAA and had it repaired a year ago. Literally his sternum was open. I could see the wires. He was going in on Monday to have surgery. And we were just trying to keep him going for a while. His vitals were fine, but all of us were like, something's wrong. Something's wrong. I'd called the doctor already. I'd done my assessments. His wife was at the bedside, all those things. Someone pulls the cord out of the wall. We go in there. He stood up to urinate, and he'd had a seizure, and he was coding, and didn't know it at the time, but his heart had dissected. So that was awesome. Awesome. We did an IO on him. We pushed fluids. We were trying to run blood as fast as we could, so we put a blood pressure cuff over the blood and was pumping it in to push it in the IO. We were, the compressions, they were not typical compressions. You could feel the blood wasn't, that there was less resistance. You could feel the blood just gushing through the heart. First time I broke ribs, you know, so your first code you never really forget. So the IO, when we busted out the drill, put in an IV, I knew we were in trouble. You have to have special training, and it's literally like a drill that goes in the bone.
They gave my daughter one.
Yeah, I think paramedics are, because they may need that in the field. So it's a special training.
I'm certified for one.
Have you given an IO? God bless you. God bless you. It's too close to the family.
Oh, yeah. Yeah.
We can. So we put ours in the leg because we were doing compressions. Right?
Bring it in.
Yeah, it's neat to see. Yeah, that's a complication of it, right? Exactly. Good point. It was weak, and it literally just dissected. It already had surgery. It had a cabbage. It had the AAA, and then when he stood up to urinate, that pressure just, and that was awful because he was her only family. They were each other's only family.
And she was there for that whole show.
Yeah. Yeah, it was awful. And that's, these are just pictures of where those sites are. Assignments for next week, we're going to skip over to ATI Skills Module 3.0. I'll shut down 2.0. I've got pictures in here of where you can find that information. Okay. Yeah. So 2.0, you could use either 2.0 or 3.0 last week. Now we're going to be using the 3.0. I'll specify so you'll know. Then that's extra. You did great. There's no problem. No problem. And then next week, you've got those 3 prep sheets due for the Thursday class. And then I think she gave something else yesterday, didn't she? A little quiz or something?
31-point quiz on Moodle that she's going to post. We have to get 100. Take your 20.
Okay, so that's in addition to this. Keep those sheets though, because that'll help you study for the NCLEX. Make a little book. Keep all those little sheets. These are just pictures of where you need to go to do your test, so you see what it looks like. And then, like I said, MedSurg, there's always more to the story, so there's just some extra slides. I'm not going to go over it. We just talked about like where the dehydration occurs. This is more information. That's what accessing an AV fistula looks like and the process for it. That's the most common phlebitis. That's how you assess an IV. And then there's some NCLEX questions on scope of practice. Let's go ahead and take a 5-minute break and come back and hit blood administration.
Oh, we probably got to do our quiz.
Yeah.
Oh, nice. Okay. Thanks for letting me know that. Okay. Okay. I have to get through blood.
It's not on your syllabus.
Blood is on my
It's not
syllabus.
on the syllabus.
Your next week is blood. No, all we have today is chapter 13.
Yeah. Infusion therapy includes blood. The blood administration is for the skills.
Hello? It's super quick. I really want to look at it. There's going to be some questions. It's a 10 slide.
Why are we at 9? Are we trying to like?
Because we had the weather this morning and we came in late and it took us 48 minutes to take a 15-minute quiz.
Well, this is working.
No, she was done. She was done. The weather just slowed people down.
It's because you had
Yeah. Okay, I'm gonna hit this hard because you're gonna need to know some of this stuff, okay? Okay, super quick. Blood infusion. I'm gonna highlight some things, but I want you to read this on your own time. These are different blood types, things that I want you to know. I want you to know who the universal receiver is and universal donor.
The Bolivar right now is 11:30. It's like 45 hours.
So on this, you can print my notes, and that's really helpful too. O can give it to anyone, and AB can take it from anyone. So that's the most important when you're trying to remember, because you have to verify the blood type before you give blood. And sometimes you're like, oh, that's not the same. Well, it's because it's AB or whatever. Transfusion therapy, ensure the patient has a 20 gauge or larger. Some products will allow 22, but in general it's 18-20. Has to have normal saline. We talked about that. You have to have assigned consent unless it's a trauma, like they come in and they can't consent because they're unconscious, right? And then you do anything to save a life until they can tell you otherwise. Assess IV site before picking up the blood. You run it kind of slow at first, and then you can turn it up. Transfusion therapy, you have to pick it up from the blood bank, and you have to confirm it with another RN. This is important. All of this slide is important, but this is especially important. Your RNs, you're confirming the identity, the expiration date, the prescription, the blood bank ID, that makes sure that the blood that you got matches the patient. The blood type and RH factor, any allergies, and ask about any previous blood administrations. Did they have a reaction before? Reactions are often like back pain, tingling of the lips, feeling of impending doom. Inspect the blood, make sure it looks good, no discoloration, gas, bubbles, or cloudiness. You have to get vitals 15 minutes before starting, and then 15 minutes after starting. If you're going to have a reaction to blood, lots of times you'll see a change in like the temperature of the patient. Blood must be started within 30 minutes of getting it from the blood bank. So if you get that blood and the patient's like, well, I want to eat lunch before you hook me up. Well, you can eat lunch as it's going, right? But you got to give it within 30 minutes. So don't wait for lunch. Get that blood in. Okay, hold if the temperature's above 100. Who checks the blood? 2 nurses. Where do they check the blood? At the bedside. You got to see that patient, and they have to have the bracelet on their body. When do we take vitals? Yep, 15 minutes before and 15 minutes after. How long does the nurse have to stay at the bedside to monitor for a reaction? It's 15 minutes minimum. How long do we have to give the blood over? 4 hours. How long after we pick it up do we have to give it? 30 minutes. Okay, you're wonderful. I like this. We talked about packed red blood cells before. It's usually given for anemia, hemoglobin under 6 or 7, depending on symptoms and other conditions. Platelet transfusions are often given, and they go faster than blood. Those are different types. These are the pieces of blood equipment when you give transfusion. These are some of the different types that you'll see. This is packed red blood cells. Acute transfusion reactions, worth knowing. Febrile, they get a temperature. Usually develops after multiple transfusions. Chills, tachycardia, fever, hypotension, tachypnea, faster heart breath rate. Hemolytic, that's when they have an incompatibility, and it starts to cause an inflammatory response, and it's immediate. And you'll stop anytime a patient has an issue with the transfusion. What do? Stop it. Stop it. We're going to safety first, right? Even if it turns out not to be a big deal, we're going to stop that blood. Even if we have to get another bag of blood because we waited too long, we don't want to give them something that's going to kill them. There can be an anaphylactic reaction, and that usually happens within 24 hours. Hives, itching, bronchospasm. Bacterial, can be contaminated. Circulatory overload, that's more common. You know, we were talking about heart patients. You got to stretch out that you give it too fast, it can overload them, or sometimes their body just can't handle that extra fluid. You'll see hypertension, overload, think everything's increased, right? Our bounding pulses, our hypertension, shortness of breath, restlessness, and confusion. There you go. Look over that before, and there's also a couple reviews on there. Those are just fun, may not be the word, but it's a good application time. Take what we talked about and apply it. I know we didn't have time to do it in class. There's some NCLEX questions in there, and it goes over how they got the answer. Not just it answers A, B, C, or D, but here's the thought process behind how you tell why it's that answer. Okay? All right. We're going to take a quick little quiz on math.
Mrs. Hendricks will be lecturing over blood admin next week as well, so don't think that we're stressed out about blood admin. She will do that on her.
Yes, Quinn. If it sits too long.